So, my topic is which and when patients to operate in chronic pancreatitis, and we all know that it is multiple causes that can cause this, the etiology is multiple, and what we need to remember is that some of the etiologies have direct bearing to the treatment planning. So, with this in mind, and we have not understood completely how the pain is generated, how the chronic pancreatitis evolves, and what is the effect of treatments strategies on the natural course of chronic pancreatitis. These are not still poorly understood. So, what we know that sometimes patient comes to us with dilated duct and multiple stone, full of stone, pancreatic stones, and without any symptoms. So, we should not jump into some sort of surgery for them in this asymptomatic patient. So, we know that the morphological changes does not always correlate well with the severity of the symptoms. Now, in the pathophysiology, if you look at the evolution of pancreatic surgery in chronic pancreatitis, you will see that initially we focused on the ductal stenosis, stones causing ductal hypertension, and we wanted some ways to drain that thing to relieve the pressure of the hypertension, ductal hypertension. So, our initial drainage procedures were devised thinking in that mind, in keeping in that mind, and we got good results, but we found out that some of the patients will not respond. A significant portion will not respond at all, and some will come back with pain again. So, there is something else, and this something else is the inflammatory part, the development of what we call is the inflammatory head mass, which is also known as the site of the pain generation, pacemaker of the pain generation in chronic pancreatitis. So, with that we devised operations which will also tackle that. So, some resection, some hybrid procedures were found out, and with that also we got good results, but even then we have a significant number of treatment failures after surgery. And unfortunately, our gastroenterologist colleague, if you look at, they are still in the plumbing problem, they are still stuck in there. Although we have moved out of that, we have encompassed the inflammatory part, but still there are patients who fail even hybrid or the resectional procedures, if you think of the morphology of the chronic pancreatitis patients. So, there are some other problems as well. And among them, one significant part is neuropathic problem. We know that that is a significant component in chronic pancreatitis pain generation. Now, there are two parts of it. It is the peripheral part and the central part. And what happens is there are inflammation in the pancreas and in the peripancreatic area that causes some pain impulse to travel to the brain and cause the pain. Now, even when you have dealt with the pancreas, you have done the resection or you have done some hybrid procedures, even if the inflammation is controlled, they still sometimes have pain. Why? Because when you have taken care of the inflammation, the afferent pathway still keeps on firing. The neurons keeps on firing, and there is pain in the pain sensation in the brain. And this is because of disinhibition of the ion channels, complex things. I don't remember much of that, but it causes something which causes, in fact, rebound pain. So, if you do some neurolysis procedure, neuroablative procedures like celiac plexus block or some splanchnicectomy, which is I have not seen anyone doing it, but if someone does that, neuroablative procedures, sometimes the pain rebounds. Why? Because there is this disinhibition, and with this there is rebound pain, and this is also true for opioid also. Sometimes patient with opioid, they will present with post-opioid hyperalgesia. So, this is important part, that once the inflammation persists for some time, there is imprint or sensitization of the central nervous system to the pain, and even when the cause is gone, when the nociceptive stimuli is not there, but still the patient feels the pain. So, this is a difficult problem to treat. So, presently there are some studies on neuromodulation instead of neuroablation, like intrathecal morphine infusion and pacemaker implantation, I mean stimulating spinal cord at specific areas to prevent the pain sensation from traveling. Now, let's come to the classical treatment approach we know. Actually, few years back, the standard was step-up approach. Now, in the step-up approach, we all know that we start with medicine. Medicine is mainly analgesics, and sometimes it is added with, to treat the neuropathic component, we add gabapentin or sort of things. And this pain medicines is purely adjuncts. They have no role in the inflammation of the pancreatitis. And if that fails, we move on to the endotherapy, endoscopic therapy. If that fails, lastly, when the gastroenterologist feels that they have done enough, at least few years of stenting and ESWL and other things, stone removal and etc., then the patient will land up to the surgeon for surgery. Now, the classical indication for surgeries are like intractable pain, as I said, when it is not manageable by medical management or endoscopic management. Biliary stricture, again debatable. Nowadays, good endoscopic therapy is also available, and there is debate whether the surgery is the first choice of treatment for this or the endoscopic therapy. But presence of malignancy or suspicion of malignancy is a strong indication for surgery in chronic pancreatitis. And other indications like pseudocyst, pseudoaneurysm, all these things, if the endoscopist or intervention radiologist fails, then they will come to you for surgery. Now, surgery, as I have said already, there are drainage procedures, there are resectional procedures, there are hybrid procedures. So, all these things are done depending on the morphology of the patient. If you don't have a bulky head, more than 4 centimeter, you go for only drainage. If you have a bulky head, you include resection. It can be in the form of phrase most commonly, otherwise Beggar, or you do just head resection also is possible. So, depending on the morphology, these options are chosen, or Whipple's or distal pancreatectomy in case of malignancy or focal pancreatitis. But there will be few subgroups where it is difficult to get good results, like small duct pancreatitis. In small duct pancreatitis, there is no target because the duct is not dilated, and even if you operate a significant portion of patients, even if you do something like Izbikis procedure or other procedures, they have not a very good outcome after the conventional surgery is what I told. Similarly, hereditary pancreatitis, it has a very high chance of developing malignancy, and pediatric patients, they again come back. They are difficult to have a complete good sustained pain relief. In these cases, total pancreatectomy with islet autotransplantation has been suggested, although done in very selected centers. I have no experience, but I can show you that this is the center of Dr. Srinath from Minnesota, and they have shown that at 15 years, they have a very good pain relief of 90%, but they have cautioned that in the toxic group, like alcoholic group, it should not be done. It should be done more in case of hereditary pediatric group and small duct disease. And 50% of patients did have preserved islet cell function, partial or complete, like good islet cell function in about 50% of patients at the end of 15 years follow-up. So, we know that endoscopic therapy is good and surgical therapy is probably better. So, we will likely to have a little dig into the literature. What does it say? That the endotherapy has a success rate of like 55 to 65% of success rate. I have quoted some papers, but not all papers are very of long duration follow-up. So, small follow-up is a problem in endoscopic trials or endoscopic this cohort studies. In the surgical group, you can see that the success rate is better than the endotherapy group. It is about 80 to 95%. So we know that, as I said in the beginning in the pathophysiology, that the longer the pain stays, there is a greater chance that the brain will be sensitized to the pain. And so the poorer outcome, even if you take out all the causative factors. So some people thought, why not early surgery? Early surgery may give some benefit of better pain control, better quality of life, and better exocrine functions. They hypothesized this. So the first trial that came out in 2003 from Czech Republic, as you see here, that at 5 years, the pain relief was 86% in the surgical group versus 61% in the endotherapy group. The criticism of this study is that they did not include ESWL in the endotherapy group. But the rest of the things, like in the surgical group, they have done drainage as well as resectional procedures. Now, this is an interesting experimental study that they did in Netherlands, that where 21 piglets, where they have ligated the PD, and then they did early drainage within 3 weeks and late drainage after 6 weeks. And they followed it up, the drainage was followed up for 6 weeks, and then the histology was checked. And what was found that histological pancreatitis scores decreased with early drainage, but not with late drainage. And the exocrine functions actually restored to near baseline level in the early drainage group, but not in the delayed drainage group. So this set the stage for the next trial, that is the this one. This came out in NEJM in 2007. And they included only dilated duct patients, no bulky head. And they included ESWL. A small number of patients were randomized, but the pain relief was significantly better in the surgical group. And this is at 2 years of follow-up. Now, they followed it up. Let's see. This is the conversion. Oh, okay, so number of procedures and number of procedures were definitely less in the surgical group, and technical success were also more in case of surgical group. Now, they came up with a longer follow-up, that is more than 6 years, the same group, and the pain relief was 38% versus 80%. Oh, already time up. So I'll just rush through the last few slides, okay? I'll just do that, sorry. So this was significant. Next is this trial that is very important, IMPACT trial, the initial study which showed a better result for surgery. And after 8 years also, they showed that the results were good. In fact, they also looked at specifically few other subgroups like early surgery group versus salvage surgery after endotherapy. And they have consistently found that the early surgery fared much better than the salvage surgery group. And trend of pain, if you look at the trend, then you see that the endoscopy group had a decrease in the pain relief over time, whereas the surgical group did not have a decrease in the pain relief over time, over a period of time. And in a separate paper, they have also said the cost was much more in case of endotherapy. Now, the guidelines have also started recommending that if you see this guideline, what is the optimal timing for surgical therapy? And they have said that early surgery is better than doing it at a more advanced stage of the disease. Similarly, this is another guideline, international consensus guideline from the working group for the international IHPBA, JPS, EPC. And they have said the same thing, and this is very interesting that the gastrointestinal endoscopy guideline that have come out in 2024, they are saying, asking the question in patients with painful CP, how does endoscopic therapy compare with surgical management? And they say in patients with painful CP and an obstructed main duct with no contraindications to surgery, the surgical evaluation before initiation of endoscopic management. This is very important. This is coming out from an endoscopy association of America. So if you compare step-up versus early surgery, definitely early surgery has got more data right now, but definitely it has to be built on more if you want to prove that. And to conclude, etiology is very important. Some of the surgical strategies depend on your etiology and treatment strategies. Pathogenesis is again similarly important. Morphological changes will decide your surgery, and early surgery is beneficial if you have to have a better pain relief over long term. Thank you for your kind attention.